my name is Nicole Aguirre. I'm going to be presenting a patient that I cared for in the pediatric general floor. The patient I cared for was a 14-year-old African American male that was brought into the ER complaining of chest pain and hip pain and bilateral lower extremity pain. He does have a history of sickle cell disease. The patient presented with chest pain for 2 days, was treating with Motrin at home with minimal improvement. And so the pain progressively got worse, and so he was brought into the ER by his mother. And he was admitted for further management and evaluation. His home meds include folic acid, 1 milligram oral tablet, oral daily, and mag citrate, 150 milliliters oral twice a day. He doesn't have any allergies. His immunizations are up to date. His past medical history includes G6PD deficiency, sickle cell anemia, and the type of sickle cell disease is S beta 0 thalassemia. The patient was hospitalized last time a month ago, where he did receive a blood transfusion for a sickle cell crisis. Developmentally, everything's within normal, no deficits were noted. Family history, no significant past medical history. His social history, he lives at home with his family, there are no sick contacts, and the mother denies any religious or cultural considerations that would affect any care. To go over the review of systems, general, he was having fever with decreased activity. Skin was normal for ethnicity, no rash. Eyes were normal, no discharge, no redness. ENT denies any ear pain, nasal congestion. Respiratory, he was reporting a cough, a dry cough, but denies any respiratory distress. Cardiovascular-wise, everything was normal except he was reporting chest pain. GI denies any nausea, vomiting, and diarrhea. And for musculoskeletal, he was having bilateral lower extremity and hip pain, reporting it 8 out of 10. And neurological denies any altered level of consciousness. So for those, basically because of his sickle cell history, my differential diagnoses kind of were based off that. So I thought of acute chest syndrome, vaso-occlusive crisis, and because he did receive the blood transfusion, it could have been a hemolytic transfusion reaction. And with his respiratory symptoms, it could be pneumonia, the infection that's triggering him. So for objective data, he weighs 60 kilos, which is in the 69.7 percentile. His height is 170 cms, which is in the 60th percentile. Vital signs, heart rate was 79, respirations were 22, blood pressure was 121/80. His oxygen sats were 98 on 1 liter nasal cannula. His temp, he was febrile on arrival, he was 101.8 axillary. So his physical examination, generally he's awake, alert, no distress, talking, skin is warm, normal for ethnicity, good perfusion, no swelling, neck, trachea, midline was normal, eyes were all normal, pupils were equal and reactive. His EMT, ears were normal, oral mucosa was normal, no abnormalities there. Respiratory-wise, he did have a cough and did have diminished breath sounds to his left lower lobe. His right lobe was clear. No respiratory distress, no tachypnea. CV-wise, normal, regular rate and rhythm. GI, his abdomen was soft, bowel sounds were normal. GMU, everything was normal. Voided down in the ER for a UA, and they reported everything was normal down there. Back was normal. Musculoskeletal, the only thing he was complaining about was his hips Pain to his hips and lower extremities, but moved all extremities. No deficits noted with strength or movement or range of motion. Neurological, no focal deficits observed. And so the plan for him was, so he did come up with already some laboratory and radiology done in the ER. They did obtain a basic chemistry, a CBC with diff, and they did a liver enzymes. They also did a UA, and they sent blood cultures and urine cultures. So for the American Academy of Pediatrics, when managing patients with sickle cell disease, they recommend when one with sickle cell disease comes to the ER and with fever or anything like that, it's mandatory to get a CBC with the reticulate counts, blood culture, which were all done early in the ER before he was sent up to us. They did do a chest x-ray which showed a left lobe pneumonia, and he was hypoxic, they said, on arrival in the ER setting in the high 80s. I think they reported 88. So they had put him on 1 liter O2 on his way up. The results for his CBC, he was anemic, did have some anemia. His hemoglobin was 9.7, his hematocrit was 26.8, his WBCs were also 21.1. His UA results were normal, and his CMP was normal as well. So for my assessment, the admitting diagnosis were the sickle cell crisis, chest pain, pain management, lower extremity pain, decreased oral intake, acute febrile illness, anemia, and left lower lobe pneumonia. And so the plan for us was to start Rocephin. We gave 2 grams IV piggyback Q12 hours. We continued his home medications, and we placed him on IV fluids for hydration. For his pain control, we also gave morphine, 4 milligrams, which he can get every 2 hours, and also Motrin, 600 milligrams, which he could get every 6 hours. The American Academy of Pediatrics does recommend continuous, around-the-clock pain management for patients that are in a sickle cell crisis. So the plan for him was to admit him, continue with the pain management, start the antibiotics. They also recommend starting broad antibiotics, the American Academy of Pediatrics, for sickle cell patients when they have a fever after all the cultures and lab work has been collected. So he was going to be admitted overnight to the pediatric floor, and in the morning we were going to obtain another CBC, CMP. And that was basically it. For improvement, one of the articles I found on Up to Date did recommend checking coagulations, and that is one thing that we didn't do. But besides that, we've followed most of the American Academy of Pediatric recommendations and guidelines. That's it.